So good afternoon. We're going to start so we can stay on time. My name is Jaime Ponce. I'm a bariatric surgeon from Chattanooga, Tennessee in the United States. And I'm serving right now as the IFSO North America chapter president. And this session is intended to fulfill one of the things that we review on the new ASMBS IFSO guidelines for new indications for metabolic and bariatric surgery. It's going to be specifically addressing recurrent weight regain and or suboptimal response to a surgery. So I'm going to have first my Italian colleague Antonio Vitello to review what the guidelines specifically say about this aspect, and then we're going to have different speakers talking not only about the definition of recurrence weight gain or suboptimal response, but also about the management with pharmacotherapy and revisional surgery in different aspects. So, Antonio.
Thank you very much, Dr. Ponce, for the introduction, and good afternoon, everyone. It's really an honor to present here in this room in front of such an audience, and also in front of Professor Forestieri, who is the honorary president of our National Congress and was my former professor. I work currently at the University of Naples with Professor Pilone. And before speaking about our systematic review, I just wanted to briefly remind you the history of the guidelines of the indication for bariatric surgery. Everything started in 1985 when the NIH had a first consensus conference, and for the first time it was decided that a patient could be defined as clinical severe obese when the BMI was over 40. In 1987 there was another consensus. This consensus was about the results of the ileal bypass, but since that was a very malabsorptive procedure, the consensus was to avoid performing that procedure. Finally, eventually, in 1991, there was this very famous consensus conference in where the indications for bariatric surgery were set, and indeed, after 2 days of presentations and discussions, it was decided that there was an indication for bariatric surgery for patients with BMI over 40 or with BMI in between 30 and 35 if they were having also a comorbidity, and it was also decided for the first time that you needed a multidisciplinary evaluation for this patient. Those indications, those guidelines have been in set for 30 years till last year when we were in Miami, and this important text was given us. In this text, some of the most important experts in our field, they had reviewed the literature and they decided that after 30 years it was time for major updates. I'm sure you are all aware of these updates. The threshold for BMIs changed, and there was also the chapter, a paragraph about revisional surgery. It was decided that it was stated after a review of literature that revisional surgery was safe and effective. But even if, as I said before, that article, the new guidelines which have been presented last year in Miami and have been published on SORD and obesity are an incredible piece of science, and the authors are some of the among the most experts in our field, it's honest to say that a consensus is still a consensus paper is still opinion, even if it's coming from experts. And if you want to write the guidelines in the modern era of bariatrics, of surgery and of science, you need a precise methodology. I'm sure you're aware that many surgical guidelines, they are written these days using the GRADE methodology, in which you give each recommendation 2 scores, one on the quality of the evidence and the other is on the strength of the recommendation, and you can give these 2 scores after a systematic review of the literature. For this reason, after a discussion in between the authors of the new guidelines, Professor Angrisani and Dr. Maurizio De Luca, they decided to hire for free a bunch of Italian fellows, and they asked us to make a review of the literature on each single topic. I know that the topic of this session is the weight recurrence, weight recidivism, or the definition, but as I think Professor Grieve will tell us later, because there is a precise lecture on this, unfortunately there is not a common and shared definition for weight regain in our field. So we could not make a systematic review on this point, but we did a systematic review on revisional surgery because we wanted to see which was the burden of weight recurrence in revisional surgery. For this reason, we did a systematic search in PubMed, MBS, and Cochrane, and we searched for the string of terms that you can see in the slide. And it's important to say that we decided to include only papers after 2000 because we wanted, to include all the papers that were including modern procedures. And we also decided to include only papers with more than 50 patients and describing more than 2 revisional procedures. This decision was taken because we wanted, in literature you can find in this moment 100 of single paper coming from a single center describing a single type of procedure, and so a systematic review would have been quite impossible. We wanted to include all those articles that could give us a big picture of the revisional surgery. We found, as you can see from the Prisma flowchart, we included at the end 26 articles. And these articles were included almost 5,000. At the beginning, we found almost 5,000 articles. We went down to 26. All these articles were published in between 2009 and 2023. And this is a very important result. You can see that weight regain or persistence was the main indication in the vast majority of the articles that we have found. In the older articles, maybe malnutrition was another important, very common indication, of course, because in the past such type of malabsorptive complications were more commonly performed. And among all these articles, you can see some trends. You can see that now, of course, laparoscopic surgery, bariatric revisional surgery is performed mainly laparoscopically, and there is a trend toward robotic surgery. And also, the vast majority of these revisional surgery are revisions from restrictive procedures to gastric bypass or other stapled or hypoabsorptive procedures. And as you can see, the operative stay, weight loss, operative time, length of stay, weight loss, and comorbidity remission is comparable to metabolic and bariatric surgery in primary metabolic and bariatric surgery. So the conclusion of our systematic review on revisional surgery is that we found evidence supporting the new guidelines, because as it has been stated in the new guidelines, bariatric revisional surgery is safe and effective because it can induce further weight loss, can induce further remission from diabetes, and hypertension and the other comorbidities. But most importantly, you see the main indication is still weight regain or weight recurrence, so it's very important to find a common and shared definition, because on the base of this shared definition, we can start deciding when performing a revisional bariatric surgery for weight regain. Thank you very much for the attention.
Antonio, thank you very much. So we're going to try to save the questions for the end, but because you did very well with your presentation and you had like couple of minutes, so I was going to ask you, the revisional surgery, as you know, the literature, even though it has a lot of evidence of support, the level of evidence is not as strong as for primary procedures, correct? Do you know what was the level of evidence that you find on the systematic review that was done for the guidelines?
Well, I must say that in our study, as I told you, we decided to include, articles not only on one single type on revisional surgery, but those giving you a big picture. And I must say that in these articles, we actually found that the indication was quite clear as for primary surgery, because the results were optimal. I think patients were losing more weight, they were achieving remission from diabetes and hypertension. So I think the evidence is that bariatric revisional surgery is indicated as such as primary surgery.
But no randomized clinical trials that you can find in revisional surgery. Yeah, so So it was basically more level 2, 3
Yes.
and
yes.
below. But,
Very low quality, yeah, that's true.
but there's enough information in the literature. So thank you very much.
Thank you very much.
And so now I'm going to ask John William Grave to talk to us about how to define, how do we define recurrent weight gain or suboptimal weight loss, which is the new terminology that we're going to start using to define this process. Thank you, John.
Well, thank you very much for the introduction. And of course, thank you to the organizers for inviting me to present. And maybe I can have the first slide. Okay. Well, I think the previous speaker already spoiled my whole talk by saying there is no definition for weight recurrence, but I'll do my best. These are my disclosures. And this is my current case mix. As you see, I do mainly endoscopic procedures now as I retired from my hospital. So it's endoscopic sleeves and balloons, but also some surgery. This is the overview. I'll talk a little bit about terminology, which is quite important as it's changing really in time now. And then some standard reporting, and then try to define success and recurrence. Now, this is a nice overview from a paper by Dr. Bonnevrie from the Netherlands, one of my PhD students, where you see the primary effect of surgery, and then you have some recurrence. And it's very important to realize, of course, that obesity is a chronic and progressive disease. So we should stop starting terminology like weight loss failure, insufficient weight loss, weight regain. Our colleagues from the cancer department also don't use this kind of terms. They don't have a failure of a treatment, they have a non-response. And that is what we should be doing, I think, in bariatric surgery or bariatric and metabolic surgery. So stay away from these terms. Talk about primary responders or primary non-responders, secondary non-responders, which means weight recurrence. So you stay away from all these more degenerative type of terms. To talk about primary non-responders, you also have to know what is the primary responder. And when you look at the literature, well, there's so many definitions. We all know about the Reinhold criteria, which defined success as a remaining percent excess weight loss of less than 50%. You also can look at how much of your excess weight was lost. Come back to it later because this is not a very good measure. You can say, okay, the BMI has to go below a certain limit. And you can even look at patients that have a very high BMI or patients that have a lower BMI and see what the supposed success is. Now, when you look at the guideline that was published by IFSO and the World Gastroenterology Organization, success is defined as a weight loss of more than 50%, excess weight lost, or BMI below 35, or more than 10% total weight loss. I think that's probably a writing error because I think that we all agree that it should be at least 20%, but anyway. But there's no reference in any of these definitions to comorbidity or quality of life. And it was in 1998 that this BARO system was published, the Bariatric Analysis and Reporting Outcome System, that includes all this, but the problem is that it's relatively subjective, and this has never been adapted as a standard way of reporting success. It's also important that we should be using uniform terms to report weight loss, which is, and it was nicely summarized in a position statement of the Dutch Society for Metabolic and Bariatric Surgery. We should not use percent excess weight loss or percent excess BMI loss for that matter, because it's the same, because it's too unreliable. A very low BMI will have a very high percent excess weight loss with only a few kilos, so that's not something we should use. We should use percent total weight loss. It's very reproducible, and that's the measure that all our colleagues from the non-surgical treatment of obesity use, so why not use the same? Now, we talked about the primary responder, but what is primary non-responder? So not reaching the limit. What do we define as a successful treatment? And again, this is from a paper of the American Post-Operative Weight Recurrence Task Force, the POWER Task Force, and they summarized, and again they showed, well, excess weight loss in percentage is an option, or excess weight loss after 18 months, but probably, and I think that's the way to go, is you should report on percent total weight loss, and when it's less than 20%, you can say that it is a primary non-responder and not insufficient weight loss. We should get rid of those terminology. So this is a primary non-responder, 20%, less than 20% total weight loss over time. Now it becomes more difficult, but now, because when you start talking about secondary non-response or patients with weight recurrence, then when you look at the literature, and this was again a summary from the group from the Maxima Medical Center, Dr. Bonouvry, she found like more than 20 different ways of describing when a patient has a weight recurrence. And even more recently, from the same POWER task force, they had more than 30 different definitions to define weight recurrence, ranging from any weight gain until nearly complete recurrence of all the weight. So what should we use? Well, we all know that when you look at the natural course of an operation, that you will have a nice weight loss for 1 year, 1.5 years, and then you reach a nadir, and nearly all patients will have some weight recurrence and some kilos, and even they can eat more easy, but when the weight remains stable, that's perfectly okay. But we don't have, and it was already mentioned, a standardized definition of weight recurrence. So when is it significant? Is it this 1-2 kilos already? Don't think so. Is it the patient perception of success? Should we look at our insurance companies when they start to reimburse the treatment for weight recurrence? Well, I don't think that's the good way to go. When should we intervene? Should we wait until there's a very significant weight regain? Weight recurrence, I should say. Should the comorbidities be a leading thing to decide when it's really weight recurrence? Well, one of the things that we have to realize is when you gain weight, it's much more difficult to lose the weight. This is already an old publication in the New York Times, so most of you will know it. It's the program Biggest Loser, where people were in a competition to lose most weight within a year, and then you got a big prize, and you can see they were quite successful in losing a lot of weight, but when they looked 6 years later, well, most of the patients had regained the weight, had weight recurrence. But what is more important, when you look at the energy, at their metabolism, and they were measured before the program, and 6 years later, all these people still had a very significant reduced energy expenditure, metabolism, compared to before the program. And that is just by exercise and diet, etc. So there's not even a surgery involved. So what is very important to realize is that when you have weight recurrence after any type of treatment, it will be much more difficult to lose that gained weight with a next step in your treatment, be it intervention with a multidisciplinary team, medication, surgery, whatever. And also after surgery, this is already a very old study that we did in Maastricht, where we looked at sleeping metabolic rate, which is very reproducible. When you look at the measured and the calculated rate, after surgery, there's a very significant decrease, and that remains over time. So the patients have to keep a certain way of reduced intake to keep their weight. Now, can we predict when weight regain is significant, when weight recurrence is significant? You see, I'm still struggling with the new terminology myself. This looked interesting, a simple performance assessment of bariatric procedures from a group in Ghent in Belgium. But when you translate the acronym, Survival Analysis of Interpolated Weight Trajectories in a Markov Chain Assessing Predictors, Longitudinal Total Weight Loss, Individual Procedure Success, and Relapse Events, well, I'm afraid it's not that simple. So in my view, this is not the solution. Another study, which could be interesting, is from the group of Apovian, who looked at weight recurrence in their patients and looked at the speed of the weight recurrence. So you have a nadir weight, all the patients will have a lowest weight that they will reach. And when they start getting weight recurrence, you can look at how fast it's going. And you can divide it in 3 different groups, mild, moderate, and rapid. And when it's a rapid weight recurrence, then probably that is the patient you should look very closely, start intervene very early, because when you have more than 1% in 1 month of weight increase, that is in 6 months, 5 kilos, 5% total weight loss, and then, of course, it becomes significant. So that is about the best way to look at it, and I'm afraid I have no further option than to come to these conclusions. It's very important to use a standardized, so we should do that everywhere, way of reporting weight in percent total weight loss. The current best parameter of primary non-response is less than 20% total weight lost. And when you look at weight recurrence, that is really much more difficult. You need to detect it early, intervene, as far as I'm concerned, early. Maybe use this algorithm that the group of Apovian proposed. Maybe when some patient reaches a percent total weight loss, which is less than 20% or more than 5% total weight increase, that could be an indication, but there's a real need for standardization. So thank you for your attention.
Thank you very much. Can you stay at the end for the discussion?
Yeah, absolutely.
Thank you.
Okay. So now we are calling Dr. Lee Kaplan. We'll give a speech on where do we draw the line to define a non-responders. Dr. Kaplan.
Kaplan is not here, huh? So Dr. Lee Kaplan is not here. So is Marina Korean here? That's interesting, huh? And Dr. Phil Shower is not here, and Dr. Mufi not here. It's amazing, huh?
We declare close the session.
So, well, while any of them come over here, do you have a contact information from any of them? So can you, Monique, can you text Phil Shower, Marina, if you have Mufi, and just tell them to wait for them. So I was going to bring up a comment and question for Jan. So, you know, I saw that you finished your conclusion that, you know, ideally we should use percentage of total body weight loss, and ideally 20% is your line in which you demarcate, you can come over here, demarcate to see if there is a suboptimal response. So I think that there is a little bit of perception that all the procedures need to perform at the same level. And I do think that there are different therapies with different level of effectiveness or response. I wonder if, that's one of my proposals for, and I know this is an unsolved issue, but one of my proposals is to have a level of response per procedure. For example, we have plenty of randomized clinical trials on sleeve, on bypass, duodenal switch, and so we can look at the average mean, we can look at the standard deviation, and then we can actually create a percentile of response. And so I was wondering if in the future can say, well, this patient is in the 90th percentile response, in the 50th percentile response, instead of saying, you know, just because he didn't lose 20% total body weight loss, he has a suboptimal response, but a percentile per therapy, because medications have a level of response and endoscopy procedures have a level of response. So what do you think about if we in the future call it a percentile, this patient is in the percentile, like you see kids on their weight, you know, the percentile that they have on weight?
Well, actually, that's a very good remark, and I had it in my presentation because you saw I already ran over time. I left it out. But looking at individual patients, Then, of course, these percentile charge, and there is a Dutch publication on that, calling it the weight loss, which is calculating and looking at percentiles. So when you have a low way in the graph, like birth weight, it's very similar. Then you can predict that the patient will have a lower end result. We have another speaker here.
Yeah.
And talking about percent weight loss for different procedures, yes, I think 20% is not very discriminating. When we look at our Dutch, the data results, 20% is not discriminating between gastric bypass or sleeve or any other procedure. Right. We can even move up to 25% total weight loss. But there are two things that you can look at, compare procedures and success of treatment. And in most patients, 20% will be okay in terms of comorbidities, etc.
Yeah, I mean, I think the first thing would be just to divide the level of response of each therapy. You know, each therapy, you cannot compare the level of response from a sleeve versus duodenal switch. And yeah, duodenal switch is going to have 20% total body weight loss much easier than the other one. So I think we need to just balance.
We do Bennett bypass, and we are not satisfied when it's not above 30 to 35% excess weight loss.
Yeah. So
sorry, total weight loss.
My suggestion is just to create a percentile based on standard deviation, and then now you know. I mean, that patient is in the 90th percentile. Great. I mean, it's in the 20th percentile. That's very poor response, and so you can demarcate that.
Yeah, that's definitely a way to go into.
My proposal. Thank you.
Okay.
Anybody else has any questions in regards to the definition of recurrence weight gain?
I would like to say weight recurrence, but
I know,
recurrent weight gain is.
So this weight recurrence is the definition that was proposed by the SMBS, and it's been proposed by many other people. And the latest consensus meeting from IFSO, it was proposed that we call it recurrent weight regain.
Forget the regain.
I know. It is.
No, you can also talk about secondary non-responder. I mean,
yes,
like in oncology. There's a microphone
no, come
right
on
here.
To the microphone, please. So if you have any questions, just come into the front to this microphone so we can hear you.
Wow. I have a question about the definition, and it's whether we should be including something more like the patient's perception. In other words, should we also be including things like satiety, lack of satiety, lack of appetite suppression? Because what patients are telling us, that after their primary procedure, they go, gee, I feel as if I'm eating more. I don't have that same satiety that I used to have, after my sleeve bypass or whatever. And I think apart from just a total weight loss definition, we should probably also include things like satiety or lack of appetite suppression or hunger and things like that, because that will also drive further intervention. In other words, do we need to include pharmacotherapy to suppress the patient's overall appetite? Because we all know that after a period of time, their appetite does increase.
I totally agree, but the big problem there, because the patient perception of what is a good weight after surgery is not what we know is all very well, like a BMI of 26 when you come from 40. They want a BMI of 20. And when that perception is, by this particular patient, is very strong, he will never be satisfied, whatever way you look at it. So that makes it more difficult to use patient perception. But I totally agree that we should look at a much broader picture than only weight loss.
Yeah, I mean, I 100% agree with you. I mean, I think we need to look at quality of life issues. I think many things that the patient considers more of a success thing than necessarily the weight. You're totally right.
But the % total weight loss is the only objective way to tell anything for the moment.
Very good. Thank you very much. So now that we finally found a speaker, Marina Curran is actually our ASMBS president, and she's going to talk to us about the use of pharmacotherapy to rescue weight recurrence after bariatric surgery.
I'm going to shorten it a little because Jan is only 6'5" or 6" or something like that. Okay, Thanks so much. Thank you for the opportunity. Something I've been talking about a lot, mainly because I medicate most of my patients now. Viva is the only one that you have to consider as potentially a conflict. I am going to be talking about all the medications and not particularly focusing on the one that is the Viva's product. And this is my case mix disclosure currently, my total case volume. Okay, so what's out there? What can we do? Pills and shots, guys. And Natan said earlier in a different call, he said, you know, I'm Colombian. I only talk about medications, not drugs. But basically, I feel like I'm a drug pusher up on the Upper East Side when I put all these patients on medication. I want to run through some of the meds that are out there. Metformin has been around for a long time, has some anti-aging effects. So, you know, if you want to look good, maybe just take metformin, 500 milligrams or so. But you can, most patients can expect about a 0 to no weight loss to 15 pounds of weight loss. And the cons for this is that they can experience some diarrhea. Phentermine is the one, it's sort of the gateway drug for all surgeons. So many of our weight loss surgery colleagues are like, I don't prescribe GLP-1s or all the other ones, I will only prescribe phentermine. You're supposed to do it for 3 months, but under the care of a physician, you can offer it for a much longer period of time. And actually, I had a patient come in who was on phentermine for 5 years. But you have to be careful, and you could see in the con situation what you have to watch out for and some of the common side effects. But you should only expect about 5% total body weight loss. This is phentermine topiramate, and similar to the phentermine, you get some dry mouth, etc. Because of the topiramate, some people feel foggy. I'm going to have a separate cost slide so you can see what it is in the US. I know it's different across the world, but you have to be careful in patients with glaucoma and also childbearing age because the risk of cleft lip palate with topiramate is significantly higher than in the normal population. This is another medication which is available. Oh, by the way, Qsymia is not available, the phentermine topiramate not available in Italy yet, but it is in the Nordic countries. I think it's just been released. So it's a great drug, but not available here yet. Contrave is another one, naltrexone, Wellbutrin. It is pretty good, but it's a lot of Wellbutrin. If you think about some of your patients, they're on 150 to 300 milligrams of Wellbutrin. This is 360 milligrams of Wellbutrin. So it's a little bit more. Sometimes people, my patients will be like, I feel like I'm taking something. And I'm like, you are. You're taking a drug. Yeah, but anyway, so they really notice it though. And the contraindications, you cannot take it with other narcotics because of the naltrexone, and you have to be careful with some of the other antidepressants, worried about SSRI syndrome. So let's talk about GLP-1s. I'm sure everybody is sick of talking about GLP-1s. Liraglutide is the one that is not the most effective, but it was the first one that was out for the treatment of severe obesity, and it does get about 10% total body weight loss in the initial trials. Side effects are constipation and reflux, especially if you have some GERD to start with, but you have to be careful with personal history of pancreatitis and familial medullary thyroid cancer. These are some of the other GLP-1s that are out there. Byetta and Bydureon, extremely old. Trulicity, interesting, because dulaglutide just went from 1.5 was a high dose, and then when semaglutide came in higher doses for weight loss, they actually added, maybe not because of it, but at that time they had higher doses, and those higher doses, which are 3 and 4.5 milligrams, really work pretty well in our patients, although these are all, not Saxenda, but Ozempic is all for diabetes. Now, these are the 3 drugs. These 2 are available now for, and that's liraglutide and semaglutide, are ready now for treatment of obesity and severe obesity, but tirzepatide is coming soon, and that is the GLP-1 GIP, and we think it's going to come at the end of this year, if not early in January. And it's variable weight loss, but you can get up to 15% total body weight loss. Tirzepatide in higher doses is supposed to get you to about 22% total body weight loss, which is pretty tremendous. And this is just the same thing about semaglutide and the higher doses, what you can expect. and this just shows you something similar. This was a daily dosing instead of the weekly, but it's still really good total body weight loss at 16%. And this is, for us, we're calling it Mounjaro. They have to change the name of the drug when they make it for a different indication. But currently, this is for diabetes, the GLP-1, GIP receptor agonist. And you can see up to 22% total body weight loss with this. Oh, okay. So this is just a slide. You can snap a photo if you want, just talking about what they all do and what the expected weight loss is. I'm going to keep it here for a second. And then I think there was some mention earlier about weight loss trajectory. This was a great study that talked about, the above average group lost 42.85%, compared with the average group, and then the below average. And I think this is where your assessment of weight loss trajectory is very important. You also need to look at their medications. There's some meds that will definitely increase their weight recurrence or prevent their weight loss. And those drugs are here. These are the ones that can impact. And most importantly, if you just think, how many allergy meds? Oh, did I do something bad? What happened? Can we have oh, there we go, thank you. So allergy meds, Zyrtec, Claritin, whatever the other names are for them, I'm sorry, but when they're on them, they actually can have poor weight loss. I'm not able to forward it. Could you go to the next slide, please? Okay. This study was very interesting to me because depending on when you started, the weight loss was the same, whether you were at a plateau or a weight regain. You lost equivalent amount. However, if you looked, next slide, okay, I got it. So if you look here, the patients that took the medication at weight loss plateau, hence why I said we should look at trajectory, they actually lost a significant amount more weight than the patients who had regained weight. So it's important to look at that trajectory and start them earlier than later. And then this is an early study talking about it was better to be on an anorectic drug like phentermine, but now we're talking more all the other studies that are coming through, and you've seen probably many discussions this week already. Liraglutide is the one, this study showed a significant decrease in patients' total body weight loss, and at half a year, they were at 10% total body weight loss on this medication. So my strategy with these patients is the first fall off when they're not losing adequate weight, when I see them in between at 3 months. First weight gain, I hit them too with drugs, and I always increase the frequency of visits. This is just stuff that I'm sure all of us do, but I do make an attempt to calculate their resting energy expenditure, and I do that with a SECA analysis, which is like a Tanita, just to measure that. And many times I may start one drug and they lose weight and they plateau, and then I add another medication. This is time consuming, and if you have a medical physician or I have nurse practitioner or PA, I train them how to do this because it takes up a lot of time. But this is the kind of things that I do in my practice for patients. So just to conclude, look at medications as an opportunity for initial medical weight loss before surgery, but it's also great for maintenance and also if you're trying to improve their weight loss trajectory, which is very important because you can maximize. Think about this construct, and I may not get through all my slides, but here. We're so used to taking patients from a BMI of 40 to 50 or greater to a BMI of 29 to 37. What if we do the surgery and then we get them, and even our obesity medicine colleagues are excited about this, we can now normalize BMI with meds. So it's nice to partner, it's nice to add medications to surgery, and I think they are really adjunctive therapies. You do need to motivate your patients, though, for sure. We do have to talk about what diet is best for them. I always tell all my patients that are on drugs, eating less of what you want is not, oh, I'm going backwards. How did that happen? Okay. Eating less of what you want does not work. They should be moving, but I think medications are excellent augment, and simultaneous use is best if they are not on the good trajectory. This is my last slide. And it's just about the costs in the US of what the patients have. Thank you.
Thank you. Marina, are you gonna Are you going to be able to stay for the discussion?
Yes?
Yes, perfect. So go ahead and present it.
Lee is here.
Okay. We move on to the next speaker of Professor Lee Kaplan. Where do we draw the line and how to define the non-responders? Please, Professor.
Not the correct talk.
So we need to change the presentation to Lee Kaplan instead of Phil Shower. We skip it. So that was the one before the previous one.
Thank you. So thanks to the organizers and the chairs for this session, for inviting me for this talk. I've redefined my talk a little bit. I'm calling it Defining the Clinical Response to Metabolic Surgery. Here are my disclosures. They don't have any bearing on the talk I'm giving. One of the things I've been impressed with at this meeting is the adoption of distribution of your own procedures as part of the disclosures that has now seemed to be routinely implemented. So here are mine. So when we think about obesity, we of course frequently thinking about the metabolic complications, but I want to start, rather than with the metabolic complications, start with the heterogeneous group of cancer-related complications. And these are the NIH listing or diagram of obesity-associated malignancies in women. And they didn't have prostate, so I added prostate at the bottom there because that's also associated with obesity. And Ali Aminian has shown in his paper from last year that both the incidence and the mortality of these cancers can be decreased with metabolic surgery. But that's not the final answer, and that's really not what I'm here to talk about today. I'm here to ask a few questions. Is this benefit, for example, dependent on weight loss? We've spent the last 15 years describing and debating whether the improvement in diabetes is due to weight loss or is due to something else related to the surgery. If it is, in part due to weight loss, how much weight loss is required for the benefit? And is it the same for all types of cancer? And I use this as an example to emphasize that the response, the clinical response to metabolic surgery is quite variable depending on what you're trying to solve, what problem you're trying to solve. And these different cancers are each a different problem. Now we know that even modest amounts of weight loss can improve diabetes, but more weight loss can do it better. And if you look at this list from a paper, this is an updated version of a table from a paper that's now 8 years old, you see that there are different amounts of weight loss that have been demonstrated to improve comorbidities or complications, but in all cases, if you have more weight loss, you get a better effect, or at least that's what it appears. We also have talked about, and many people have heard me talk about, the fact that every kind of therapy, including metabolic surgery, has a broad distribution of outcomes in individual patients. So what we're dealing with now is a series of diseases that are caused by obesity, each one of which has maybe a different profile in terms of what kind of weight loss or what kind of efficacy of therapy you'll need to improve that complication. And every therapy that we use has a variable response across the population of patients that we apply it to. So now we have two sets of variables that we haven't been able to reconcile just yet. So I'm going to talk about two examples now of how it is we could approach this problem. The first one is a study of about 300 people with NAFLD, mild NAFLD, who were given 52 weeks of lifestyle-based therapy. So it's a 750 calorie per day deficit diet, and the average weight loss was only 4%, which is what we would expect. and the average change in NAS score is 1.6, which is a modest change. By comparison, bariatric surgery has been shown to create a greater than 3-point change in NAS score. But the reason I'm showing this particular study is because look at the effect of weight loss on the outcome. So this is not weight loss by surgery, it's not weight loss by the new drugs, this is weight loss just by eating less. It's acute weight loss, not chronic weight loss, but you see that the remission of steatohepatitis is very much graded by the amount of weight loss. And in fact, this is the study that led to the idea that we need 7 to 10% weight loss to improve non-alcoholic steatohepatitis. Now let me switch to another study, a study that was published only last Sunday. And this is a study called the STEP-HFpEF trial. This is not the major study report which was published in the New England Journal last Friday. This is the second paper which was published well, this first slide is from that New England Journal paper. The next slide is from a second paper. And I'm not going to go through all the data except to say that the overall efficacy of semaglutide, 2.4 milligrams per week, for improving HFpEF is summarized on this slide, which shows it's a composite, complicated assessment. But if you look at all of the patient-reported outcomes, exercise capabilities, and overall risk of having an acute event from the heart failure, what you see at the top line here is that the overall benefit was substantially better for people who are on semaglutide than people who are on placebo. And the win ratio, which is which wins, which side wins, was more in favor by far of semaglutide. But the question was, how much weight loss do you need to get those benefits? And they did that study, and this is the second study published in Nature Medicine this past Sunday. And they looked at different amounts of weight loss. All of these patients that I'm going to show you in this particular slide were on semaglutide. So everybody had semaglutide. This is not the control group. And if you look at physical functioning, which is how far you can walk in 6 minutes, what you see is that less than 5% weight loss, even on the semaglutide, was not associated with improvement. But even a 5% weight loss or 5 to 10% weight loss was, and there isn't much more improvement as you see all the way above 20%. If you look at patient-reported outcomes, which is a well-validated survey instrument that talks about quality of life and capability of doing activities of daily living, et cetera, you see that 5% weight loss had very little effect. The big jump was when you got less than 5%. Big jump was when you got from 5 to 10%, with a progressive increase, but a modestly progressive increase thereafter. But compare that to the improvement in immunological function shown here in the next part, which is this is immunological function. Again, now the good side is on the left. And what you see is as you get more and more weight loss, the immunological function as measured by CRP gets better and better and better. And suddenly, now for this particular outcome, again, all these patients have HFpEF, heart failure with preserved ejection fraction, but it's graded, much more graded. The more weight loss, the better. So different outcomes, same disease, same patients, same therapy, but different degrees of dependence on weight loss. So if we're thinking about addressing a suboptimal initial response to surgery, there are multiple options we can use. We can substitute for the obesogenic medications that Dr. Kurian was just talking about in the previous talk. We can reinvigorate lifestyle treatment. We can add one or more of the newer or older anti-obesity medications. We can add a bariatric endoscopic approach. We can modify or revise the metabolic procedure. We could convert to a new procedure, and you know the new consensus guidelines from IFSO say we separate out revision from conversion. But each option has a different risk-benefit profile, and of course they don't have to be used alone, they can be used in combination. So if we're going to assess the cutoffs, which is what I was asked to do, for suboptimal initial weight loss that would cause us to do something, we were looking primarily at the people who don't do as well on the left side. I'm not saying that the blue square should be the cutoff. I'm just saying that we're looking at the left side to see if we can do better for that population of patients. And so if you were to have a 15% cutoff in total weight change, this is not excess weight loss, then this is what it would look like for gastric bypass. If you were to use a 20% cutoff, you'd get another group. And if you were to use a 25% cutoff, you would get a different group. And the question is, which group do you want to define? And it really depends on what your outcome is. And so, whoops, sorry. And so the other thing is, it also depends on which operation, because you get a different response if you're doing gastric bypass from sleeve gastrectomy. As you can see here in this study that was published earlier this year, sleeve gastrectomy in this study averaged about 92% as much weight loss. But if you look at the distribution that sits under these average curves, what you can imagine is that the people who got sleeve gastrectomy, a lot more of them are going to qualify as inadequate or suboptimal weight loss if you use a 15, a 20, or a 25% cutoff. And so if you want to sort of summarize that, the way it looks then is looking at these data from Spain. That was the data that compared the gastric bypass and the sleeve gastrectomy. The portion of patients that would meet the criterion if you used a 15% cutoff for sleeve gastrectomy would be 5%, and for gastric bypass a little under 2%. If you used an 18% cutoff, it would be 10 and 7%. And if you used a 20% cutoff, it would be 18%, fully almost a fifth of all patients getting a sleeve gastrectomy would meet the cutoff for suboptimal initial weight loss. But as I've already told you, weight loss alone isn't the goal. The goal is improved health. But which health is improving? And so in conclusion, I would argue, if I can make this go, that there's no currently consistent means of determining the optimal clinical response to surgery. Categorical definitions of responder and non-responder, which was the original title of my talk, based simply on BMI or percent weight loss, characterize individual patients as either successes or failures, which can reinforce stigma on top of being not a valid way of assessing anyway. Suboptimal initial response to surgery allows for a more continuous description of benefit and is viewed differently depending upon the initial indications for the surgery. How much obesity the patient has, how severe the obesity is, the type and the severity of the complications, and I showed you a few examples of how that would work. Very different for cancer, for liver disease, and for HFpEF. There are widely different efficacy and risk characteristics of the different therapeutic approaches to suboptimal initial response. Medications are different from endoscopic interventions, are different from revision and conversion surgery. Thus, the indications for defining suboptimal clinical response that should stimulate more therapy actually has to be individualized based on both the patient's needs and the treatment that's being considered. The criterion for using a drug are probably different from doing an endoscopic procedure, are probably different from either revising or, more importantly, converting from, say, a sleeve gastrectomy to a DS or a gastric bypass. Thank you very much.
Thank you, Lee. Before you leave. So while you're there, I'm just going to ask you a quick question and comment that I did before you came into the room, and it's just more appropriate to what you presented. So I think it's unfair to try to put a number like 20% total body weight loss for all the therapies, while each different therapy has different level of response. And so knowing now that we have data, level 1 data, randomized clinical trials, sleeve, bypass, OAGB, duodenal switch, can we, instead of that, just put a bell-shaped curve, determine what is the mean, what is the standard deviation, and then say, this patient had a sleeve gastrectomy and is in the 90th percentile response or in the 50th percentile. Do you think that's more appropriate than just have a cutoff for all the procedures?
So I agree with you. I don't think a cutoff is the right answer. I think a cutoff is a very crude way of assessing. But I also think the percentile is not good enough either, because if you're coming in because of cirrhosis or early cirrhosis, you might need more weight loss to reverse some of that fibrosis than somebody who's coming in with diabetes, and they need a lot less weight loss in order to get the benefits that have already been proven in these trials. What I would say is we have, in the new consensus statement, there are some consensus statements that say the determination of success, or the determination of suboptimal initial weight loss or recurrent weight gain, is one of the criteria for success. But another criterion is how well the patient did for the complication of obesity that is the indication for surgery. Not just any complication, but the one that's the indication for surgery. And then use that kind of clinical information to assess how the patient does. It doesn't work well with governments and policymakers and insurers. They want a number. But I think we have to argue strongly that a number is not the right answer. Good clinical care is a better answer.
Thank you. And if you happen to stay for the last part, we'll combine some of the other questions. And if you have to leave, that's fine.
No, I have, my next talk is later.
Excellent. Thank you. So did Phil Shower made it to the room? Not really, huh? So Mufi is here. So you wanted to introduce him? So we're going to go to the next talk. So the next two talks were response to the two most common surgeries, which is the sleeve and the Roux-en-Y gastric bypass. So Dr. Mufasala from India is going to give us the response to the gastric bypass. And if Phil Shower comes in, we'll talk a little bit about the sleeve response. Thank you. So
Thanks,
we're going
Jaime.
to the let's talk.
Here we go. So I'm here today to speak on that's my procedures, and as you can see, my major procedure is the Roux-en-Y gastric bypass. It's a little modification from the older type of Roux-en-Y gastric bypass that we used to do, where we used to keep a half meter or 1 meter biliopancreatic limb. I've increased my biliopancreatic limb since then, just because we've had to do a lot of revisional surgeries post Roux-en-Y, and they're not very easy procedures to do. Well, the main reasons for revisional surgery after Roux-en-Y gastric bypass remain inadequate weight loss or weight regain, weight recidivism, and complications basically related. So let's keep the complications aside and concentrate on the weight loss or weight gain. Well, the definitions remain 10 to 15% of nadir weight or 10 kgs from nadir, BMI of 5 BMI points, and an increase in BMI of more than 35 remain the average criteria by which we decide whether the patient needs revisional surgery or not. Now, most of the common predictors for weight regain remain old age, gender. Females tend to have put on more weight regain, higher preoperative BMI, mental health conditions, presence of diabetes, and other chronic diseases like cirrhosis and maybe other chronic kidney disease. Hormonal, metabolic, dietary non-adherence, which remains one of the most common reasons, physical inactivity included, and non-adherence to follow-up. So these three things are the ones that we can do something about in terms of behavioral therapy. And eventually, anatomical surgical failure, which I'll try and concentrate on during the you did hear a lot on the drugs and various drugs. Today we have the GLP-1 analogs, the amylin receptor analogs, and various other things that can cause various growth. But in terms of revision of procedure, this is IFSO Registry 2022, 45% of the Roux-en-Y gastric bypass needed some form of revisional surgery. So in terms of actual numbers of revisional procedure, Roux-en-Y gastric bypass remains the #1 procedure. So what are your goals of revisional surgery? Well, restoration of gastric restriction, because it's, as we thought previously, restriction along with malabsorption, add more malabsorptive component if you need more weight loss, and eventually aim to achieve both together. Surgical revision of the pouch, so various options that you can do if you have an anatomical failure is surgical revision of the pouch or the gastrojejunal stromal size, or placement of an adjustable or a non-adjustable ring on top of the gastrojejunal anastomosis. Eventually, lengthening of your biliopancreatic limb to cause more malabsorption. We do know that type 1 lengthening is far better than type 2. Conversion to a SARD-S or a duodenal switch, of course, depending on your skill sets, depending where you come from, that totally depends on whether you do it 1 stage or 2 stage. Now let's look at salvage banding for failed Roux-en-Y gastric bypass. Well, this is a result of around 9 studies that were included in this review report. And they did report an increase in weight loss for salvage banding for failed Roux-en-Y gastric bypass. And they said it's a safe and feasible long-term procedure. Not too many patients, as you can see, in a total accumulation of more than around 70 patients odd that we have in this study. This is from George Fielding's study, again, talking about the adjustable gastric banding, and they said that you got a decent weight loss, but not long-term results in any of these studies. Now, when you looked at a reversal of the long-term weight regain following a liraglutide in comparison to applying a ring on top of what we saw is that there wasn't too much difference, and liraglutide is not even as powerful as semaglutide or tirzepatide. So maybe that adjustable gastric banding or putting a ring on top of the pouch might not be the best answer, in my opinion. As you can see, you can achieve that with just mere drugs. So where do we go? Well, we go next to what we would think in terms of around 14 studies were conducted in terms of pouch size, in terms of anastomosis size. And these randomized studies found that larger pouches were associated with far worse weight loss and diabetes outcomes. So therefore, pouch size, according to these 14 studies, did really matter. So we concentrate on the pouch size. So in this large multi-center international experience and meta-analysis on endoscopic revision, what are the endoscopic options that you do have? Well, you could use APC, you could use TOR, or you could use the newer ones, which is full thickness resection and suturing. Now, at 12 months, you got, in a study cohort of around 130 odd patients, you got around a 20.2% weight loss and a total body weight loss of around 6%. So that was, according to them, pretty decent. Now, if you look at the TOR in terms of weight regain, weight loss journey of these patients, it did kind of stabilize and didn't allow the progression of weight gain to happen. So endoscopy is probably the least invasive of all procedures if you were to consider doing a replacement. Now at 6 months, if you look at this, 18.5%. So best results were at 6 months. And then as we tailed off to around the 5-year mark, you realize that there was weight regain and you had only a 7% weight loss at 5 years with the TOR procedure. Again, this is something in terms of resection and TOR. And when we compare these two various procedures, if you look at whether gastrogastric fistula was present or gastrogastric fistula was absent. When you look at them at 6 months, again, the best weight loss results in terms of 19% if fistula was present, and in terms of only 13.8% in terms of if the fistula was absent. But at 3 years, it again went back to 8% and 11% if there was a gastrogastric fistula, which was expected results. Now, this is the modified ESD plus TOR, and you have various techniques of doing this, resecting the entire thing, taking your sutures, as Chris Thompson told us, either in a circular purse string fashion or in this fashion. And what the purse string fashion currently, along with addition of either semaglutide or tirzepatide, has given them up to 21% weight loss, and therefore that's pretty good according to them. Now, when we looked at other things, all right, in terms of weight regain after this, if you looked at revisional surgery at 2 years and 5 years, if you look at the 2-year numbers, it's just 5. In terms of number of procedures, it's very, very low. And therefore, it's very difficult to predict long-term outcomes with this number of procedures being just 5. If you look at it again over here in terms of weight regain with the gastrojejunal anastomotic enlargement in pouch narrowing surgically, if you look at it at 1 year, the results were good, 64.1% excess weight loss. But when you drop down to lower, it came down to 42.7%. Again, weight regain was seen with just gastric pouch and gastrojejunal revision. If you look at this in terms of trimming of the pouch with redo, this is from Raul Rosenthal's and Simon Somstein's paper. What they did say is that amongst all these 3 things, the only thing in this critical thing in this study was that your number 2 group and number 3 group, B and C, didn't have enough numbers to statistically tell you. But what they said is that it's a safe enough procedure which gives you at least decent weight loss in terms of either undoing the anastomosis or doing an anticolic and a retrogastric anastomosis. This is what their paper said. Now, in terms of increasing the biliopancreatic limb, well, this is where we go. Increasing your biliopancreatic limb does give good sustained weight loss even at 6 years in terms of excess weight loss, BMI loss. In terms of complications, we do know that you will have steatorrhea, you will have protein energy malnutrition, you will have deficiency in terms of vitamin A, D, E, and K. So you have to be careful once you go malabsorptive. Again, in this, Eric Di Maria's, this paper, what they did notice is that at 30 days and at 3 years, weight loss, total bodily weight loss was all very good and maintained in this group. Super obese patients, of course, only had a little less weight loss than the non-super obese, but again, significant weight loss with type 1 biliopancreatic diversion. Good resolution of comorbidities as well, post-distalization, but again, good remission of diabetes and everything. Again, the only problem was that you had deficiencies if the tall went below 400 or 450. In terms of, again, limb lengthening, this is another study from Scott Shakura's group, again, showing the same thing. At 6 months or at 24 months, the weight loss was very, very good. Again, deficiencies, you can see that everything was low except ferritin was high, which is bound to be because iron was low. Limb distalization is good enough procedure as long as you're ready to take the deficiencies that come. Now, in terms of converting it to a biliopancreatic diversion, this is a very good procedure in terms of good long-term weight loss. Go through this rapidly because you don't have too much time. And what it's shown is that you have very good outcomes, long-term sustained weight loss, one of the best procedures to do in terms of 6 months as well as 1 year. And if you were to compare a SARD-DS or a BPD-DS, BPD-DS worked far better than the SARD-S, however, not statistically different in terms of nutritionally, SARD-DS worked better than the duodenal switch, but long-term weight loss was far better with these. So in terms of changes of BMI here, you can see that there is a difference between SARD-DS and BPD-DS. And this was an average overall. If you look at BPD-DS, if you compare it with a distalization procedure, a banding on the pouch, a pouch revision, endoluminal, the various weight loss options are there. This is what I wanted to present in my last slide as to how I decide in terms of a weight regain procedure. If someone came with inadequate weight loss or weight regain, I would look at the percentage of weight regain and the comorbidities associated, whether the patient was a super obese patient to start with or not. If you had less than 50% of weight regain post the bypass, and there was good satiety, I would look at behavioral therapy and drugs. If you had more than 50%, then these patients would straight away go for either type 1 distalization, a BPD-DS, or a SARD-DS. Now, in terms of if the patient didn't have satiety, I would look at the anatomy. If the anatomy was good enough, again, behavioral therapy, drugs. If that failed, they would go for one of the surgical options. But if you have an abnormal anatomy, gastrogastric fistula, I would just go and resect the fistula either endoscopically or with a surgical excision with fundectomy. Dilated pouch, I would again use endoscopy, the new modified TOR approach with some drugs. And if that failed, eventually I would consider surgery. A long common channel, of course, the options would be to try drugs first, and if that didn't give significance, then you go into picking the type of surgery. My procedure of choice would be the SARD-DS over the DS. Thank you.
I don't see Phil shower yet here, isn't it? I was going to ask Lee, Kaplan, Marina, Jen, can you sit over here so we can discuss a little bit what we have? And I was going to ask all the panelists and presenters, so do you think that we have today an algorithm to manage a typical patient in BMI in the 40s that had bariatric surgery, sleeve bypass, and has an inadequate response to the surgery, meaning maybe less than 20% total body weight loss? And what will be the first initial approach that you will use? Will you use medications? Do we have any level of evidence to start using anything, or we go straight to revisional surgery just because of the inadequate response? Lee?
So I think comes back to we need to look at the patient clinically. If the patient has a very dramatic and rapid, well, if they have virtually no response or they have a very rapid weight regain, then the first thing I would do is evaluate the patient for looking for some problem with the operation.
So anatomy is normal and multidisciplinary assessment has been done, but just the weight is suboptimal, initial.
So then I would look and say, what's the history of the patient? If the patient has previously been on the medications we would use today, then I would probably be thinking either about new medications that we haven't used for that patient, or be saying we need to move to a more significant intervention, either by bringing a new mechanism of action. So one way of bringing a new mechanism of action might be some endoscopic approach, but the most likely way of bringing a new mechanism of action is to do a conversion operation. And I emphasize the difference. You said revision, I'm saying conversion, because the revision that just tweaks for somebody who has significantly lower than expected initial weight loss or has substantial weight regain is something that I would just move to a more aggressive stance. However, for the majority of people who are only modestly underperforming in terms of their initial response, or only modestly or at a relatively slow rate regaining weight, I would use a drug first.
So Marina, I'm familiar with the randomized clinical trial that was done on inadequate response to bariatric surgery. There is a randomized clinical trial that is called Very Optimize. It was done in England, 70 patients, half sleeve, half bypass, and in 1 year, at least 1 year, lose less than 20% total body weight loss. And they were managed initially with liraglutide at a maximum dose, 3 milligrams. And there was a significant difference in weight loss in between placebo and treatment group, 8%. Are we aware of any other data, even not level 1 data, in response to revision surgery for management with pharmacotherapy?
I presented, I think, 2 studies in my talk, right? So, Lee can back me up, and also you guys, the GLP-1s do fantastic in our patients because it stops it seems to modulate their insulin response. Of course, it only works if they're actually trying to be low processed carb and things like that, but otherwise they are, it really helps their satiety, it helps disassociate them from their food cravings to, in many cases, which is what, New York Times did a article on food noise in all of my patients, and the other doctors have latched onto the term, and I don't love the term, but it's for example, your patients that think about what they're going to have for dinner starting at breakfast. Now, those of you who are married know that that also conversation happens with your spouse because you're trying to figure out what's for dinner, right? But this is like every moment of their day, they're thinking about what they're going to eat next. And so these medications tend to stop that internal dialogue, and it helps them because they're not feeling snacky because they had something and then their sugar bottomed out. These medications really are great, and I've been saying this for years. It took me from 2 revisions a week down to 2 a month, but it's a lot of work. And but it does help the patient, which is the most important part. So I, as a solo physician and a surgeon in private practice, it's hard to do, but I've had to hire help to do it. But if you guys have access, it keeps the patients, it helps them, and it also helps you identify the patients that will likely benefit from a revision and yet still ongoing help. Some of the patients will come to you and say, I just want you to operate on me again. I'm like, you're being a little crazy because you want me to cut you and do stuff to you instead of just trying this medication that I know is going to help you. So you have to kind of get through that. But but the medications work.
I think it's good to have tools and avoid surgery as the beginning. So I'm going to let Lee, because he wants to have a quick comment on that, and then if anybody else has a comment, and then we'll let Phil Schauer present his talk.
Yeah, so my only comment is both the Gravitas study, which looked at a lower dose of liraglutide in patients with diabetes after gastric bypass, they were not selected by inadequate or suboptimal weight loss. They were just after gastric bypass. And the barioptimized study that everybody's referring to, which were patients who didn't do as well with the surgery. In both cases, the weight loss from the liraglutide, and the second one was at a higher dose of liraglutide, the weight loss from the liraglutide was greater than the average weight loss for liraglutide all by itself. And that tells us two things. One is the potential that the drug and surgery are synergistic and not just additive. That's number one. And number two is many people believe that because the GLP-1 levels go up after bariatric surgery, that's what causes weight loss. These two studies both show that that's not true. If that were the way of the weight loss, giving more GLP-1 wouldn't solve the problem. GLP-1 is helpful in improving the diabetes, independent of the weight loss. But the GLP-1 that causes weight loss is made in the brain and secreted in the brain and acts in the brain. The reason that the drugs work in the brain is because they last in the body for a week. Normal GLP-1 lasts in the body for 1 to 2 minutes. And so that being the way they're structured is that they provide a complementary mechanism having nothing to do with the mechanism by which surgery causes weight loss.
It's a different mechanism. Any other quick comments? Yes.
Yeah, well, it's great that we have now this huge armamentarium of really working medications, etc. But one of the issues that have to be solved then is that you saw the graph with the cost of the medication is when you need to put your patient permanently, and you need to put it permanently on the medication, and it's about $1,000 a month for the liraglutide, or even...
No, it went up.
It even went up. Yeah. That is something that needs to be solved. But it's really, really amazing what they can do.
Yeah, this is a problem that I want to explain to people why it is the way it is. Every new drug in the United States, at least, probably around the world, but every new drug is very expensive. All the new drugs are. But in most diseases, think diabetes, think hypertension, think Crohn's disease, the new drugs are not used in most of the patients. The old drugs are used in most of the patients because they work. But we don't have old drugs that are going to be used in large percentage of patients because they're not nearly so good. Over the next 10 years, these drugs are going to get cheap like everything else, and then they'll be usable in everybody. But for the next 10 years, we have the challenge that you described. And so that challenge is going to influence patient choice. It's going to influence our choice. It's going to influence the government's and the payers' choice. And so we're just going to have to learn, and we don't know this yet, which patients need to be on that kind of therapy despite the cost, and which patients are just going to have to take another approach. And it's a very strong argument for using surgery, and I think it's an argument that it isn't because the drugs are bad, or it's not because the drugs are expensive. It's because today the market looks like surgery is going to be a cost-effective alternative to drugs rather than drugs being a cost-effective alternative to surgery.
And if I just may, the drugs, like, so for liraglutide, it's coming off of patent, and it's going to be made generically and not by Novo anymore. I don't believe that they're going to continue to make it, is something that I heard. So, but the other companies will be able to make it. And for us, anything that's coming from the US, it's 10 years on patent. So actually, in January also, phentermine topiramate is going to go to generic. And, you know, I mean, this is what we're watching. Like Ozempic is going to go, which is semaglutide, is going to go in 3 years, I think. It was originally put out in 2016. So when that
2029 for that one.
For Ozempic?
For Ozempic, yeah.
Oh, that's weird, because it's been up.
Yeah,
Okay.
it changes. They do
Yeah.
all kinds of
And the indication is different, but anyway.
It's the same medication.
It's the same, yes.
Yeah, there was actually a publication in JAMA that I saw with the lineup of FDA number of years that they have. So it's actually, many of the medications are in the late 2030s. I mean, all these new medications, it's going to be a long time. Well, thank you. What I'm going to do is I'm going to let Phil Shower present, and then may have a chance for one question or so, and then we'll finish the session. Thank you, Phil.
Okay, great. The slides, please. Sorry for my tardiness. I was at another lecture that conflicted with this. But I'll be talking about perhaps what's emerging, at least, is the most common revision across the globe. That is revision of sleeve gastrectomy to something else. Now that we're 10, 15 years into the sleeve as the most dominant procedure worldwide,
Slide, please.
It should be no surprise.
Can you put the slides of Phil Shower? So we skip him before the last presenter. Thank you.
Yeah, so it should be no surprise that we're seeing this emerge as the most common revision. And I must tell you, it's a daunting task in 10 minutes to give you a complete overview. So up front, I will apologize because some of these comments will be just a very, very broad summary, of the literature. But there's lots of reasons to convert a sleeve gastrectomy. The topic for today is essentially weight regain, but understand that often these overlap. The two most common, weight regain and or GERD, and often they come together, and it's anyone's argument as to which one is the dominant one. But when you look at the potential options, you have 1-2A gastric bypass type procedure, Roux-en-Y or the OAGB. The re-sleeve, I'm not going to say too much about re-sleeve because there's just not much long-term data. And as Dr. Kaplan would say, this is not really a conversion, this is a revision of the initial operation. And in most cases, that usually doesn't produce good long-term results. And then you have the reduced absorption operations like duodenal switch, and I'll throw SADE in that as well. And, one of the first systematic reviews was quite a number of years ago, but the results really haven't changed that much. In this early study, 11 studies, 218 patients, the BMI after the revision to a Roux-en-Y, drops about 7 to 8 BMI points. So about initially, nadir, 60% weight loss to about 48%. So that's what you get, with that procedure. And with that generally comes comorbidity improvement. And in general, the complications are slightly higher than if you'd done the sleeve as a primary procedure. And here's some of my own data from Cleveland when I was there, where we looked at 90 patients who had a sleeve converted to Roux-en-Y gastric bypass, and these were patients that had fairly high comorbidity, as shown here. And there were 3 primary reasons to convert, shown in the columns here. Some of the patients were high BMI and planned for a 2-stage. Some of you might call that, okay, that's inadequate weight loss. We thought it was expected inadequate weight loss, but we counted that as a revision. And then there were those that were not as high BMI that actually had some degree of weight regain or performance, low performance weight loss. And there was a group that was entirely different, those that had a complication of the sleeve, whether it was an obstruction or reflux or whatever. And you can see here the complications profile in quite a bit of detail. And just to summarize it, our findings are very similar to what everybody else has shown, that the complication rates, whether they're infectious, obstruction, bleeding, are a little bit higher than a primary procedure. And these procedures are pretty effective with diabetes. The revision to a bypass, just summarize that here, the mean A1C was 7, and at 2 years later, dropped to about 6.1. That's about a 0.8% drop in A1C, and about 36% of the patients had a complete remission overall. So fairly effective in terms of diabetes as a revision of sleeve to bypass. It's also pretty effective at improvement in reflux, and that's a common reason. And about 75% of the patients who had reflux from the sleeve became, essentially had a remission of their reflux after conversion to bypass. And most of the meta-analyses show the same thing. And what about weight loss? And this is important. In looking at, both groups, the planned 2-stage versus the weight regain of the primary operation, you see that the change in body mass index, again, is about an 8-point drop in BMI. So if your patient's BMI 45, you're probably going to see it drop to about 38 when it's, when they reach their nadir 2 or 3 years out. Percent weight loss, 13 to 16% overall. Excess weight loss, 25 to 30% with this revision procedure. And pretty much all the meta-analyses showed the same thing. Now, what about competing operation, the OAGB, as a revision? And this is one meta-analysis, and it's interesting, it's funny, there's so many meta-analyses that deal with almost the same studies, but have different conclusions. But in general, with this meta-analysis, with the OAGB, you tend to get a little bit better weight loss than you would converting to a Roux-en-Y. No surprise. Perhaps that longer BP limb that may be driving some of that better weight loss, generally 200 to 250 centimeters. However, not as good for GERD, and in some cases introducing a new problem, bowel reflux, which is reported in 7.4% of the patients after the OGB. So, in my opinion, the Roux-Y versus OAGB, they're probably comparable. One slightly better with weight loss, one slightly better with reflux control. And then when you compare the OAGB versus Roux-en-Y in this meta-analysis, or I'm sorry, this comparative study, that's exactly the conclusion. A little better weight loss with the OAGB, but the Roux-en-Y may be better for overall reflux control. What about going to the more aggressive reduced absorption procedures like a duodenal switch? And here's one meta-analysis that actually includes all the procedures: the duodenal switch, the single anastomosis, duodenal ileal bypass, SADE, gastric bypass, either one anastomosis or Roux-en-Y. And the results were, as you might expect, you're going to get superior weight loss when you go with one of these more aggressive malabsorption procedures, compared to a gastric bypass or one anastomosis gastric bypass. But one of the problems with many of these studies is the follow-up is still, early to mid-term, not looking at the 5, and 10-year. And many of the studies for the malabsorption procedures don't have adequate data on the nutritional deficiencies. And that's really, really important. If you don't include that, you're sort of missing an important aspect of that procedure and an important, long-term risk. And just to give you an example, here's one study that has very good, it's a small study by Rubino and Mangroni, including, this is for diabetes, biliopancreatic diversion, gastric bypass, medical treatment. But I'm showing this not so much for the diabetes benefit, but for the risk profile. And even with a sample size of only 20 patients at 5 years, if you look at the BPD population here, you see a fairly significant percentage of nutritional problems. 26% anemia, 16% hypoalbuminemia, which is equivalent to protein-calorie malnutrition. Osteopenia, 16%. Osteoporosis. A lot of these meta-analyses don't incorporate this degree of information on these long-term nutritional sequelae. Probably the best paper on this for BPD is the group out of Canada, which really were the champions of the duodenal switch procedure. Picard Marceau and his group there, where they reported on 1,000 patients, the BPD DS procedure with 10-year follow-up. And I'll quickly go to looking at the nutritional, the rates of nutritional deficiencies. And if you look at low albumin, whether you call it mild in yellow or moderate in gray or severe in orange, you see a fairly significant percentage of this problem that stretches out over that 10-year period. So this is something one has to factor in to the equation. If you look at actual rates of albumin and rates of deficiencies, 8.5% deficiency, hemoglobin, 14%, calcium, 20% deficiency, and very sobering, vitamin A, 21%. Vitamin A is hard to track, It's not often included in your typical annual follow-up profile, and vitamin A deficiency can lead to irreversible night blindness. So these are rare, but these are very serious complications that we have to address, particularly if we're going to adopt these malabsorption procedures. And here's just more data on metabolic bone disease, which can occur as high as 30% of patients after these procedures. And a lot of these meta-analysis studies, again, are not addressing those issues. So there are a variety of options that surgeons have, and it's like anything else, it's always that risk benefit profile. If you want the greatest weight loss, it's easy. Convert a sleeve to a DS or a SATI, but the price that your patient is going to pay, probably a small percent, are going to perhaps get into trouble with their nutrition problems. In my opinion, in general, your better option is a sleeve to either a Roux-en-Y or a single anastomosis gastric bypass. And I think I'll stop there. Thank you for your attention.
It's already close to, it's very 4:01. So anybody has any quick question before we close the session, just go ahead.
No, okay, it's worked. Thank you for this excellent session. And Alexander Neymark, my question is, and when we need to start therapy, because we discuss about weight regain, when it's the time to start the therapy? After weight regain, or when it's start immediately, or we start
When you say therapy,
sure.
Do you mean medical or surgical therapy?
Medical
Therapy, yeah.
Medical therapy.
I don't think there's any answer to that. There's only a couple papers that even look prospectively at adding medications. Now, just my opinion would be to identify the full benefit of the surgical intervention. At least take the patient to their nadir weight, which is usually 12 to 18 months. And if they are not reaching an optimal weight loss defined as their comorbidity improvement, that's the time to add the drugs, in my opinion.
Yeah, I agree. Wait until you're at that nadir. If they don't reach it, then start it. If you reach it and start seeing an elevation, then you may start considering the medications there. But I think it's the same way that you would apply surgical revision, even for the sleeve.
Exactly.
Yeah. So thank you very much, and look forward to finish this Congress. Thank you.